Right, a very good afternoon to all of you. Good afternoon, INS India. Welcome to the November edition of IV Talks. And thank you so much for all the encouragement that we have received so far on IV Talks. You all have been quite consistent in all the sessions. This one is really a very important session. And as you know, we have had the same session in the month of March. Many of us missed out that session due to some technical, glitches. That was the very beginning of IV Talks. So now, thank you, Abdul and the team, to please take it up and come back to the INS forum for this very, very, very informative session on CVAD excellence, empowering oncology nurses and patient in care and maintenance. So this session would be taken up with the HCG team, and we would be having a detailed discussion on this topic. As usually, we would be having, questions from your side, real-time scenarios discussion, as we always do in IV Talks. Please feel free to drop in your questions in the chat box or in the Q&A box. The speakers will take up those questions. And to start the session for the official flag of today, we have Captain Madhukari Ray. Madhukari ma'am is the Vice President INS India, and ma'am would be officially flagging off the session. Madhukari ma'am, you're
Thank
there?
you.
Yeah.
And yeah, good morning, everyone. Thank you, Pooja, for giving this introduction. And I really feel fortunate enough to be one amongst you to be here in this session because Ivy Talks is very close to my heart. And so as for Colonel Binu, even on behalf of Colonel Binu, the CEO of INS India, I must congratulate the sector, the center for taking up this initiative and ensuring that we excel every day in IV practices. And this the topic. Today's topic is very, very essential for all of us to understand that central line, right from any type of central line, is very, very difficult and at the same time very important for each and every nurse. It is not only the ICU nurse, it is not only the PICU nurse, but it is equally important for even ward nurses, because with the time that we have seen, the scenario in healthcare is changing. And with that, even the semi-critical patients are kept in the wards, where we are having many patients even in the wards with central line. We may not use central line in the wards, but at least we'll have to maintain the line with doing proper flushing as per the protocol, the institutional protocol. So that is very important for all of us to know and develop skill every day with this. So this is a theory part, definitely, but I think it is also essential that we keep lot of skill stations also to develop the skill, the knowledge and skill, both the practical point of view that needs to be enhanced for each and every nurses. So I thank Polymed, Miss Dr. Atul, Puja, for taking this initiative. Of course, this is one of the initiatives which we had been running for from month of January, and it is really, wherever we are doing, whichever chapter is taking this up, this is really becoming a boon for everyone to learn in an aspect that we hear from patients, we get feedback from patients, we get feedback from clinicians. So there are lot of areas where we can actually show our expertise and gain the confidence. So this is one of the initiatives to gain the confidence as a whole from INS India with our industry partners. So I feel really, once again, I thank all of you for joining here and making it more fruitful, more successful. I wish all the today's speakers are going to do a lot of value additions in terms of learning. And Abdul, thank you very much for taking the lead. So always I feel happy to see you in this crowd, and because I know how much efforts you put in for to ensure that nurses learn. So once again, thank you to all of you for joining us, and let us take the session forward. Thank you once again.
Thank you so much,
Thank you.
ma'am, for encouraging us always. And now, taking it further from here, let me invite our moderator for the session today. He's the co-chair with the Karnataka chapter as well. Though we miss Saroja ma'am also, she is our co-chair, but today she is not available. So yes, Abdul is taking it forward. Mr. Abdul Dhyan Razak, he is the Associate General Manager, Nursing Operations and Quality from HCG Group, and he is our Karnataka chapter chairperson, and he'll be our moderator for today. Over to you, Abdul.
Thank you so much, Pooja, for that. And thank you, Polymed, for having this particular program run successfully for all close about 1 year now. And thank you, Central Team, Vinu ma'am, Madhukari ma'am, for all that wonderful support. Whenever we pick a phone and ask them, it's already done, it's granted, it's something like that, permitted to run a program. So thank you so much for that, constant support. That is the reason why states are able to perform, better, and we are able to spread this particular essence of IV safety, which is kind of a niche area. Again, we are trying to build in a culture of safety for patients through IV cannulation, either it can be central or peripheral. Okay, so going towards today's program with a beautiful topic called CVAD Excellence, Empowering Oncology Nurses and Patients in Care and Maintenance. And I'm proud to represent an organization which is leading oncology care in India. From an organization of HCG with my team of members. I have my senior consultant, medical oncology. I have my infection control nurse, my senior infection prevention control nurse, and my clinical nurse specialist who will be handling the session today. So with no delay today, the first session is all about choose it right, fix it right. With this particular topic, I invite Mr. Venugopal, who's my clinical nurse specialist come vascular access nurse specialist of Healthcare Global, my flagship hospital here at Bangalore, Kalingarav Road. And he brings an expertise of oncology nursing. He was onboarded as a novice nurse at HCG with his potential of showcasing a different talent. He was chosen to be a clinical nurse specialist. Then, with the empowerment, with the knowledge what he shared along with the clinical team, and we chose him to be a vascular access nurse specialist. And along with him, I have one more colleague of him who are handling a PIC clinic where they handle PIC clinic 24/7, where consultants do prescribe the PIC insertion. These particular kits take up from there, right from insertion to maintenance to monitoring to follow up and the rest of the thing, the care, what is going on. So over to Venu. Thanks for joining and thanks for being here. Just give me a moment. I'm trying to share the slide of Venu Gopal's.
Thank you, Abdul sir, for the nice introduction.
Just give me a moment, please. Just let me know if my the slides are visible. Can you see the slide?
Yes, sir. Yes, it is visible. Just put it to slideshow.
Yeah, I'm putting it. Done.
Done. Yep.
Yes, Venu, you can go ahead.
Yeah, thanks, Abdul sir, for the nice introduction. Thank you, INS and Polymed team, for giving me this opportunity. Yeah, today my name is Venugopal A. I'm a CNS nurse in this hospital. I work as a access nurse specialist. I take care of central lines, this thing and all. So I'm going to talk about, title is choose it right and fix it tight. We're going to speak about the topic. First of all, what is cancer? Cancer is uncontrolled cell growth that can invade surrounding tissue and spread to the other parts also. It is called as metastasis. Once it spread to the other parts like surrounding lymph nodes or other parts of the body, we call it as metastasis. So what is the treatment option for this cancer? We'll speak about the next slide. How to cure or control this cancer now. We have many options like we have surgery or radiation, chemotherapy or combination therapy, hormonal therapy, immunotherapy, targeted therapy, bone marrow transplant. To succeed all of this, like any treatment options, we need like CVAD help. So we are going to talk about main topic as a CVAD topic today. So what are the forms of chemotherapy? We give like intravenous chemotherapy, oral chemotherapy, that is like tablets, and intramuscular or subcutaneous injections, or intraperitoneal chemotherapy, intrathecal, we give as a intrathecal methotrexate and all, and intraarterial chemotherapy also, and topical chemotherapy. Like 80 to 85% of the chemotherapies are like in the form of IV chemotherapies. So, and remaining other like intramuscular subcutaneous and are like takes 5 to 10%. Like intraperitoneal chemotherapy also we need like CVD help, and IV chemotherapy like 80 to 85% as I said. Uh, how to give like IV infusion therapy? We next speak in next slide. Like mainly through like peripheral access, whether we have to give all the chemotherapy medicines through the IV cannulation or else PIC lane, like in the sense of CVAD, central venous access devices. We have many access devices available in the this thing. Central venous like chemo port, PIC lane, ICMAN lane, or chemo port, implantable ports. And intra-arterial form also we can give intrathecal also. So now importantly we speak about peripherally inserted central catheter, that is PIC lane. Now like what is the way like vein consideration for PIC lane placements and all? Mainly we choose like a basilic vein, brachial vein, or cephalic vein. How we have to choose, like whether certain factors influencing vein selection also depends upon the like depth of the vein, size of the vein location and path, and patient specific factors also, like patient had earlier any thrombus and or patient has underwent already like any previous chemopotting implantations or any PICC line insertions earlier, and ultrasound guidance also influence, and any contraindications like any thrombosis history of previous history of thrombosis and all. Next slide. So no additional consideration like previous CVS placements. Yeah, as I said, decreased mobility of the arm. If patient is not moving hand, so DVT chances will be more. And coagulopathy also, like we check iron or PTIN and all. If any bleeding tendency will be there, so after putting PICC line, bleeding chances will be more. So that is the reason we check coagulopathy profile and decreased mobility of the arm and all. Any contractures also, so we choose it like opposite hand, like or any previous history of shoulder surgery or previous chemopotent catheter insertions. Now how to assess? We'll see the insertion site assessment and hygiene and PIC patency and dressing assessment, patient's overall conditions, arm circumference, catheter placement, and documentation. For CVD, just to maintain like care and maintenance is very important in this thing. Not only like PICC line insertion, putting PICC line and sending the patient. Patient education is very important. There is a reason we have mentioned all the assessment is important. Insertion site, we have to observe for any bleeding, any redness, any oozing is there. So immediately patient has to report. Hygiene in the sense of like patient attender also take care of the hygiene and all. If they don't like bath only, or whether they have to cover it up the PICC line, this thing we have PICC line shower covers are, so they have to cover up with the pickle shower cover and take bath. If water goes inside, then tecatum comes out. The infection chances are very high. That is the reason hygiene is also important, and pick patency. How the like backflow, free flow. Every 7 days once we check this thing backflow and free flow and all, and dressing assessment also. Any in between redness, oozing and all, patient needs to get dressing immediately. And the patient's overall condition, like patient it comes like a patient is moving their hand, they're doing exercise or not, and arm circumference, like if patient is develops DVT, patient hand swelling may come. That is the reason we'll check arm circumference also if there is swelling of the hand, and catheter placement and documentation is very important. Next line. Now we go into the picture insertion, this thing procedure, how we are going to screen the veins and select the veins. We have to explain the procedure, overall procedure to the patient and patient attendants, how frequently we do dressing and what are the estimation cost, everything, and what are the complications and infection chances and all. We have to explain the patient and attendant, and we have to explain the patient. This is the vein, like black color circular, it is in circular form, where we see this is the basilic vein which is away from the artery. Brachial artery and brachial vein will be together. So mainly we choose it to the basilic vein because it is away from the artery and it is 1 or 2 centimeters deeper. So infection chances are very less when it is deep. And this is the jugular vein, we are screening it. Any DVT, previous history of DVT, anything. And carotid artery we can see in the picture. Yeah, this is the jugular vein. In the ultrasound machine, like vein it will close like this, it collapse. If you press with the probe, it will collapse like this. Artery doesn't close, it will be palpating. This is the procedure we have recorded for one patient. This is the pickler insertion set with all the like guide weight, introducer, catheter, and stillet, and measuring tape also we have. This start lock to fix. Now after make it, once we make it ready, just we screen for veins, basilic vein or this thing under basilic vein, cephalic vein or brachial vein. So once you see the scene machine, we have to give local anesthesia just above the vein. We should not give like 2 to 3 ml of just 1 ml of local anesthesia is enough. If you give like too much of local anesthesia, also vein may collapse. It will compress the vein. So 1 ml of local anesthesia is enough. After giving local anesthesia, leave it for 30 seconds. So otherwise patient may complain of pain. Leave it for 30 seconds and then take a needle. Then through the ultrasound guided help of ultrasound machine, we are going to insert a needle into the vein. Once it enter the vein, we'll get a backflow. So we'll insert guide wire. Then we can take out needle and put a introducer and insert catheter. And we'll take measurement. It will be always like right clavicle notch to the insertion point plus 4 centimeters to the right side and plus 5 centimeters to the left side. It is always from right clavicle notch to the insertion point. Yeah, we got the backflow now. We're going to put like guide wire. Once guide wire is placed, over 90% of the procedure is done. Remaining only you have to fix the catheter through the introducer. This is a lateral view of the vein.
Link also has to be there.
This is lateral view of vein and now like a needle is entering into the vein. You can just see in the picture after giving local anesthesia. Yes, it is just above the vein now. Yes. Now it is above layer. It is pricking above layer, upper layer. This is how it looks. Yeah, now it is into the vein. So when it is into the vein, then we'll get a backflow. We have to put the guide wire. And next slide, please. So now most important thing is care and maintenance. If we are like only like pickling specialists or experts, we put a pickling, we explain to the patient and we put a pickling and send to the ward. Like handling is very, very important because all the staffs, whoever handles the pickling, they should be trained. They should have induction class and they should be like CNE classes frequently. So that is more important. Now what are comes under pickling care and maintenance? Dressing changes. So after putting pickling, we have to observe for 2 days and any bleeding, anything and all. So after 48 hours, we need to change the dressing. So after changing dressing, we have to just educate the patient. Any problem and all, immediately they have to inform, report to us and come to the hospital. If they see any bleeding or oozing and all, and flushing. So we have to flush the catheter with the normal saline with the push and pause technique. And later we have to flush 10 ml of Epiloc that is available in the market. It is like 100 units of heparin that doesn't cause any platelet drop on because it is only just 100 units that will be in catheter. So at last we have to give that 10 ml of Epiloc contains heparin 100 units with diluted normal saline and send close it and securing the pick. We actually use like a Statlac to secure the pick line. So that doesn't come out. Catheter should not come out. So we don't do suturing and all because suture stays like 1 month to 1.5 months, and we keep pickline like to 8 to 10 months also. So that is the reason we use secure the pickline with Statlac. And next, patient education is more important because nurses handle in the ward well and we do in dressing well. If once patient goes to home, they're like 1 week they have to take care. Attender has to take care, so we have to education to the patient and patient attender is most important thing. How to take bath, how to handle pickling, what to observe, and when to inform. Those things we have to educate the patient and attender. And surveillance also. Any infection rates, this thing and all. How many patients like insertions we are doing, how many infections are there, how many like what are the problems we are. That is surveillance and all will take care by ACN also. And next slide, please. And take home message is right line, right care, right outcome because every patient matter. And, this means like which catheter we have to put like single lumen, double lumen, we have triple lumen also. So which patient needs which line. So the taking decision is very important. If you are going to put like for 1 month for hematology patient, if you are going to put single line, it is no useful. So for bone marrow transplant and all, we need like 2 lumen power pick line. So other like solid tumors and all, we need infusion, this thing 2 to 5 days infusion. So we go with single lumen, that is closed ended catheters. So that is more important. And right care and maintenance is also as explained. It is also most important thing. And right outcome, like when patient completes treatment without any complications, that is the right outcome we see. That is most happiest thing for a patient and our hospital staffs also and us also because every patient matters. So stay safe, stay informed, and keep making a difference. Thank you. Now I'll hand out to the infection control.
Thank you so much, Venu, for that elaborate explanation and a video. This shows about the empowerment as a topic. Again and again we keep reeling on empowering nurses. So this is what we are trying to talk about as empowerment, right? At one point of a time, as nurses, we should be able to prove that we are no lesser than a care team along with the doctors. We should also be able to be in par with consultants, be in with par with treating physicians, so that they have this confidence at end of the day. Yes, I am handing over my patient to safe nurses. That is what we are trying to talk about. Yes. So with no delay, I would request the next speaker, Ms. Asha, our senior infection prevention and control nurse, who will be trying to talk about what is her perspective or what is her empowerment in a role of maintaining this particular line, or what are the infection control perspectives what she's going to look in when a patient is on a PIC line or a CVAD. So speaking about Asha, again, she holds a bachelor degree, and she started her career as a registered nurse, and she joined our organization as a senior registered nurse with her the vibrant nature and a question asking skill that made her one of a notifiable and noticed nurse at the bedside. That is how we chose her to get into infection control. And she was a junior infection control nurse, and she learned, she updated herself, she underwent lots of programs, she underwent a fellowship training in infection control, and post in that she was in infection control. Now she's leading the team of infection control along with the other infection control nurses and the link nurses under her. I'm not, if at all I'm not wrong, she has at least 6 to 7 infection control and the link nurses who are directly reporting to her, and where she works hand in hand with the infection prevention disease consultant also. So over to you, Asha, and I'm trying to pull her slide to project. Just give me a moment, please. Kindly confirm whether the slides are visible.
Yes, sir. Thank you.
Yeah, thank you.
Yeah, good afternoon, all. Safeguarding patient health. Nurses' role in CVAD infection prevention and control. Why are nurses key in CVAD infection and prevention and control? Nurses are centered to CVAD management because they are the professional who insert, access, and maintain the CVADs daily. Access for infection signs like redness, discharge, fever, any pain, tenderness. Perform dressing changes with strict aseptic techniques. Educate patient about hygiene and how to care of their lines. Prevent and detect complications early. So next slide, please.
Yes.
Yeah. Why is CVAD infection prevention especially critical in oncology? Cancer patients are high risk for infection due to several reasons. It may be disease factor, treatment proposed, outcome of disease treatment. Disease factor. Cancer itself weakens the immune systems. Many malignancies like leukemia, lymphoma can cause neutropenia. Bone marrow suppression reduces the immune cell productions. Nutritional deficiency weaken the immunodeficiency. Tumor burden can impair organ functions. In the treatment factors, cancer treatment increase susceptibility to CVAD infections, chemotherapy, radiation therapy, stem cell transplant, frequent IV treatments. So outcome of disease and treatment if infection prevention is effective. So, positive outcomes, reduce risk of CLABSI, safe and uninterrupted chemotherapy treatment, faster recovery from cancer therapy, lower mortality, shorter hospital stays, improved quality of life. In case infection prevention fails, CLABSI, due to CLABSI, sepsis, and ICU admissions, chemotherapy delay or dose reductions, CVAD removal or reinsertion, again discomfort for the patient, more procedures, increased mortality or morbidity, higher healthcare costs. Next slide. So, what to do? So, clinical nurse. Key responsibility in CVAD infection prevention. Nurses provide direct patient care, so their action have to strongest impact on reducing the infections. Their key responsibilities: strict hand hygiene. Ensure compliance with the 5 movements of hand hygiene. Hand hygiene is the single most important action to prevent contamination of CVAD and reduce the CLABSI risk. Aseptic technique. Use aseptic non-touch technique for all CVAD access and dressing procedures. Maintain a sterile field during site care. Only touch non-sterile areas with clean hands, none the sterile components. Standard precaution. Wear gloves when accessing the CVADs. Use gowns and masks if splashes or aerosols risk is present. Follow proper waste disposal and sharp safety. Consider all blood and body fluid as a potentially infected. So early identification of infection. Nurses should monitor for redness, swelling, any tenderness, pus discharges in the site, fever, chills, elevated heart rate, pain or tenderness, or increased WBC count. And aseptic and IV care and CVAD maintenance. Scrub the hub with chlorhexidine or alcohol before access the port. Plus CVAD according the policy. Some people in cancer sector you are using only normal saline. In other unit they will flush with the heparin. According your policy you can follow that. Change dressing using sterile technique. Use chlorhexidine dressing. Ensure securement device are intact to prevent line movements. So what infection prevention control nurse will do? IPCN supports clinical teams by providing guidance, monitoring, training, and system level management. So, guidance and expert consultation. Develop CVAD care policies and protocols. Provide up to date evidence based guidelines. Advise nurses and doctors through the infection risks. So, shadowing and clinical supports. Observe nurses on the ward performing procedures, how they'll perform, offer real-time coaching and corrections, identify the training needs, support new staff with the mentorship and demonstrations, monitoring and auditing. IPCN conduct audits on hand hygiene compliances, line access techniques, dressing change techniques, environmental cleanliness, documentation of accuracy, surveillance. Again, IPCN track CLAPSI rates, trend on infection type, microorganism resistant patterns, outbreak or unusual clusters, high risk patients. We are handling in the onco sector, so every patient is a high risky patient for us. So, and again, vaccination and immunization programs. IPCN promote and coordinate with staff immunizations, example, influenza, hepatitis B, TT, patient education about recommended vaccines, oncology specific immunization awareness like pneumococcal, HPV vaccines. So next slide, please. So now, how to do? For nurses, how they do it? Understand the dynamics of infection prevention. Attend the regular infection prevention training and updates. Understand how infection spreads by hand to CVAD, CVAD to bloodstream. No, the patient specific risk factors, especially in oncology, chemotherapy, due to chemotherapy, neutropenic changes, skin breakdowns, participate in team discussion about the infection trends and recent incidents, adherence to policy and protocols, follow CVAD care guidelines step by step, like dressing changes frequency, hub scrubbing time, flushing protocols. Use checklist to ensure every part of the procedure is completed. Ask for clarification is unsure to procedure rather than improvising. Report the policies and unclear or if supplies are not available. And staying abreast of knowledge, keeping up to date. Attend the services competency updates and educational workshops. Read unit newsletters or IPC updates from the IPCN team. Review updates from oncology societies or hospital guidelines. Actively ask questions during supervision or shadowing. Participate in simulations or skill refreshers. For IPCN, how they do it? IPCN supports staff through practical and some system level methods. Shadowing. Again, how IPCN do this? Observe nurse performing CVAD access dressing changes and hand hygiene. Give real-time feedback and correct improper technique gently and professionally. Demonstrate the correct method and let nurses repeat it. Identify gaps in practice. Example, not scrubbing long enough or breaking aseptic field. Surveillance. How IPCN do this? Monitor and record infection rates, monthly CLAPSI data, identify patterns. For example, rise in any infection rise in the particular ward, review lab reports or bloodstream infections, track which organisms are most common and their resistant patterns, investigate and suspect a cluster and start an action plan. Sustenance of good practice, maintaining the standards. This means keeping infection prevention practices strong and consistent over time. So provide ongoing training, offer refresher sessions when guidelines are changes, Provide reminders through posters, quick reference cards, and emails. Reward units with good complaints to encourage and motivate them. Work with the managers to ensure the right supplies, for example, sterile dressings, chloroxidine, gloves, supplements. Encourage a safety culture where staff feel comfortable the reporting the problems. Next slide, please. Again, what the patient role in CVAD infection preventions? Majorly hand hygiene and dressing. So hand hygiene, keep their hands clean before touching anything near the CVAD. Dressing care, keep the dressing clean, dry and intake all the times. How to do it? Do not remove the or change the dressing by themselves unless trained for home care. Keep the dressing dry while showering. Check daily in mirror for redness, swelling, drainage, or any changes in the site. No manipulation of the line. So do not pull, twist, or play with the catheter. Do not remove caps or touch the connection points. Do not inject or flush anything into the line themselves unless trained. So how to do it safely? Keep the line taped and secure to prevent accidental pulling. Take care of the dressing while sleeping and doing exercise. Avoid heavy lifting or movements that tag to the catheter. Inform staff if the line feels loose or if the securement device comes off. Reporting symptoms early. What patient must report immediately if they develop any fever, chills, any discharge from the site, or pus bleeding, or line feels different, loose, or uncomfortable. So next slide, please. So here the take home messages. Always you have to follow the aseptic technique. Staff education is more important and competency level, multidisciplinary collaboration, audit and surveillance. Remember, each small step towards quality care is again leap towards saving lives. Stay safe, stay informed and keep making difference. Thank you.
Thank you, Asha. That was very crisp and you know more powerful, I would say. Lots of important take-home message you have highlighted. Thank you so much for that particular thing, which shows about how focused as nurses, as patients, they should also be. It's very very important. It's not only the role of a healthcare provider, may it be a doctor, may it be a nurse, may it be specialists like you people who are trying to do lots of good thing to the patient, but it is also in turn the responsibility of every nurse to teach the patient his health and his infection prevention and control is in his own hand, right? So basic requirement of hygiene, basic requirement of an idea of infection prevention is very very important among patients also. Thank you for highlighting that more strong and more sensitive area of education. Thank you so much. And with no further delay, we have next speaker, Dr. BJ Srinivas, who is our senior medical oncologist. And Sir comes with a very rich experience and very rich expertise in medical oncology. And Sir's area of area of expertise is breast cancer, GI, head and neck, handling cases of multiple myeloma, clinical research and tumor genetics. Sir's interest is more on the clinical research and clinical genetics too, which is again highlighted and upcoming department. And Sir comes with a very rich experience, was a gold medalist in his medical oncology program. So over to you, Doctor. Thank you for joining.
Yeah, thank you. Thanks, the team, for giving the opportunity to share the clinician perspective, clinician insight. I think both of our nursing colleagues, they have presented very well. I think they are the backbone of the CVD, I mean, central access venous device. I think most probably they are the first people, people who come in contact with the patient whenever before starting the chemotherapy. And definitely, I say these are the you people are the definite backbone without which we cannot deliver our chemotherapy treatment. So I think the procedure and the safety techniques are aseptic techniques, maintenance, everything. I think you know everything. So from my side, clinician, what we want from you people, or what we expect. So those things briefly I will say in another 5 to 10 slides, I think most probably. I hope my slides are visible to you people. So these are the I mean, you are the frontline healers, compassion in action, patient advocates, vigilant observers, which is required, and care coordinators, safety guardians, and we need to tell them that what are the complications of the CVAD, I mean, central venous access device, and definitely
So
educators and
I'm sorry.
empowerers.
So can we have your slides on slide mode, please? Presentation mode.
Now it is there.
Yes, yeah. Thank you so much, sir.
Yeah. So, and definitely the trust builders between the patient and the doctors. So, definitely I
Did we lose him? Pooja, you're mute.
Yeah, I think he's got stuck. Some network problem is there.
Yeah.
So
Just wait. Asha or Venu, if you're around there, can you just check
and
with?
this is hello.
Yeah, so in between we lost you. Yes.
Okay. Now you're okay. We okay.
Yes, yes, yes.
Yeah. So this presentation outlines the clinician expectation for optimal CVAD care. So as told by our nursing colleague in the previous speech, infection prevention and aseptic technique is definitely is the one method we can prevent infection. So what we call it as a prevention is better than cure. So prevention of infection, because any CVAD infections are deadlier infections, and if we don't treat or don't recognize early, so we are going to lose that patient. So definitely prevention plays a very important role, and performing hand hygiene before and after CVAD care is required, and aseptic technique for catheter access, dressing changes, and medication administration, that I know you must be doing everything, and scrubbing the hub for at least 15 seconds before each access with alcohol or chlorhexidine is mandatory. And most of the hospital will have a hospital infection control protocol to minimize the contamination risk, and we should follow that. So dressing is also important. I think frequent dressing, maybe around 7 days to 10 days period is what we follow here. I think most of them are doing well, and we are not coming across in our HCG hospital where we are coming across with CVD infection as a one of the source of infection in especially in neutropenic patients. So it may be the other endogenous like lung infection or bloodstream infection, but CVD infections are very less often we have seen in recent past. That is because of use of the proper aseptic techniques and maintenance of the maintenance following the hospital infection control protocol. I think most probably that is the reason. And sterile transparent dressings and replace them every 7 days, or if soiled, and apply chlorhexidine based antiseptics before dressing changes. Keep the site clean, dry, and secure to prevent disgorgement, and inspect it dressing daily for signs of infection or loosening. So daily may not be possible. Patient may take chemotherapy and may go. We can educate the patient about the dressing, soiling of the dressing, or any changes in and around the dressing. So we can educate them and inform. I mean, tell them to inform as early as possible if any changes they see in the near in and around the CVAD site. So flushing and patency maintenance is definitely very important, and hospital protocols are available for flushing with saline. Use the push pass technique for effective flushing. So this push pass technique is so pushing the 1 to 2 ml, 10 ml syringe we have to take, and I think we might be knowing and we may be doing this. 10 ml syringe where 1 to 2 ml we have to push and stop for a few seconds, and then push 1 to 2 ml. So like that we can do this for at least 4 to 5 minutes. So then this will help in creating the turbulence, and whatever the minor fibrin is deposited, it will help to flush out, and whatever the drug debris because of the previous infusions, it will also help out in doing that. So so that is why very important push and pass technique for effective flushing. And the any flushing we should not force it, because it may be blocked catheter may be there, and there may be chances of the rupture of that catheter is possible. So, and we have to, if there is a blocked catheter, then we have to inform the doctor, and we have to do whether the imaging to see where is the blockage, or where is the where any malposition is there or not. So ensure proper clamping techniques to prevent blood reflux. So. mm, and manage monitoring for complications is definitely required. Monitor for redness, swelling, pain, and discharge at the insertion site. So we decide I mean divide the catheter related infection in two types. One is catheter related bloodstream infections, that is directly entering into the blood. Infection directly into the blood is there. The second one is catheter related site infection, catheter site related infection, where the catheter site may have pain, redness, swelling, discharge. So these are the two things we should the our nurses should be able to differentiate between the things. Though so catheter site related infection, definitely we can make out, and we can educate the patient. If there is a swelling, pain, redness, or any discharge, immediately inform. And whenever you come, when the patient comes to hospital and you see that site, if there is, immediately inform the doctor. And then we have to see whether associated with bloodstream infection is also there. To see that whether bloodstream infection is there, we have to take the culture route, and from the both peripheral the PICC site or the CVAD site, and as well as from the peripheral blood. And if there is a differential sign, differential growth is there, then we can say the infection is from the PICC line. So this is how usually we, and in both the type, whether it is bloodstream infection and if it is site related, both the time the patient may have the fever may be there. So we have to differentiate where exactly is the source of infection, whether it is a directly bloodstream or directly the site one. So bloodstream infection is more dangerous than the site related infection. Site related infection is a local one which we can take care of very easily, but bloodstream infection, patient needs to be require hospital admission, may be required, maybe ICU admission if the blood counts are very low, hypotension is there, patient needs higher antibiotics and ICU monitoring to get rid of the bloodstream infections, especially the catheter related. Dedicated IV tubing and CVAD, and change it as per the facility protocol. Administer pre-medications through the appropriate lumen based on medication type, and verify medication compatibility before infusion to prevent interaction, and flush before and after medication administration to maintain the patency. So this all we doing, I think, flushing and the proper medications for the compatibility we are doing. And this is more important, family education is important apart from the patient education, because there may be chances of whenever the patient is sleeping, the tube may get pulled, or any children at their families there, the tube they may try to pull it during when they take bath. There may be chances that the water may enter into that. So these are the small things which we have to anticipate and tell the family members, so to take care of all these things, and home care techniques, including flushing and dressing maintenance. And so definitely report pain, swelling, fever, any changes, that is more important, and provide written instructions for home management and emergency contacts. So documentations, I think our nursing colleague has told about this. Documentation is very important, including care records, including site assessment, dressing changes, and how much time, what time of elapsed, how much time the catheter has been inserted, 6 months, 1 year, 3 months to 4 months. So something like that we can document, and any complications also to be documented. So patient comes subsequent infection. So whether we have to take out the catheter site or maintain, we can spare the catheter. So that also decision we can take if the complications of intervention, I mean side effect, I mean the site infection is already been done, and subsequently second time, third time patient has presented. So we have to change the site itself. That decision also will help out if we document the incidents whatever happened. So report of concerns or abnormalities to the clinical team immediately, and ensure collaboration with physician, pharmacist, and infections control teams. So in every sterile dressing change, in every infection prevented, and in every life touched, you are the silent warriors of patient safety. Definitely I agree with this. So you are the first line provider, care provider for our patient. So definitely without you people, it is impossible for us to deliver the chemotherapy. Thank you once again. So any questions we can take up?
Yeah, thank you. Thank you so much, sir. Uh, we have a lot of questions in the Q&A right now and the chat box as well. So just a second. So we'll take it from the Q&A box first. Just a second, it's readable. Yeah. So the first question is, what are the most common challenges oncology nurses face in maintaining CVAD's patency and preventing complications?
Venu, are you around?
This is for me to answer.
Hello.
Yeah.
Most common challenges.
Venu, you're there. Yeah.
Yeah, doctor, you want to answer this? Probably you can also tell out
Shall I read
the
the question
experience of a
again?
clinician perspective.
Yeah, actually, for maintaining CVD patency and preventing complication, I think we have told in our slides that the patient should be educated about how to maintain the CVAD, that the water should not go in, the children should not access that, and any pain, swelling, discharge is there, they have to report, and the whatever the transparent plaster is there in and around that catheter. So if any it has coming out, dryness, the edges are rolled out. So those things we need to educate them. And so patency definitely during when the patient comes for the infusion. So definitely we check for that push and stop pause technique is there that we have to follow to see whether patency is there, backflow is not there or not, that we need to check out. I think these are the things. I mean, they should follow. I think.
Yeah, thank you, doctor. And to that particular question, what gaps currently exist in oncology nurses and competency training of oncology nurses? To be very sure that that's a very big, huge gap, I would say, because me, handling oncology in so many years now, but there's a lot of gap. It is actually oncology being a very niche area. I guess most of the hospitals feel oncology is just about giving chemotherapy. It's not about that. It is also about encouraging and empowering and enlightening the nurses who are taking care of this particular patients, because not every chemotherapy behave the same way. Different chemotherapies have different targets of organs, where these basic assessments on the organs, probably there are list of organs, list of chemotherapy which can target cardiac system. There are drugs which can target on nephro. So it's very important for a nurse to understand this particular understanding will definitely come in among nurses when we are trying to develop a competency program. Probably for anybody who is asked this question, try to have an oncology training program created, curated with the help of your medical oncologist. If you have, just understand what is the requirement and create a curative program, tailor make it according to your institution. And then what you do is create a competency checklist. Post the training program, you can assess your nurses so that whether they are having a competency based on theory. And then you can also have the company partners who can come in, who can train the nurses on hands-on. Probably, if at all you're trying to talk about CVAD, you're trying to talk about chemopod needle insertion, you're trying to talk about maintenance and care. There are lots of industry partners who are ready to train nurses, so you can train them, then certify them competent enough, and then give them a privilege. This is what we try to do. This is what at HCG we are trying to do. And this particular culture works better because we are very sure, and consultants are having a 100% assurance and confident that these set of nurses are also being trained, and involve consultant also in the training. That is very, very important, because most of the time what happens is nurses or nursing admin team train nurses very differently. We don't involve consultants in the training. So consultants are not aware, or they're not rest assured what is the competency a nurse has developed. Is she or he ready to take care of my patient? That is a big gap what we are trying to have nowadays, because that is the reason why we say this consultant is very tough to handle. He requests too many things, he's asking for too many things. The reason is we are not expecting, or we are not understanding the expectation of a consultant. It's very important, because he's a treating physician or she's a treating physician. They have their own expectations to handle the patient. So it's more important that we understand the expectation, bridge this particular gap, become hand in glove along with a consultant. There, you will never have complaints from a consultant on a negative feedback, saying that the nurses are not doing a great job. I guess this is how we have worked. We have succeeded HCG, being an HCG. I guess I would give you the same tip again.
Right. There's a follow-up question also in there. How can institutions ensure consistent, standardized CVAD care across multidisciplinary teams?
Okay, so how do you standardize it? So standardization is all about whether, as a department, have we standardized something, right? So have a standardized care pathways. For us at HCG, we have created care pathways, discussed along with all the consultants. For us, probably it is more easy because we run tumor board, we run a medical board. So nurses are a part of that, including the chairman of this organization of HCG is a part of tumor board, where the decisions are made there. So it becomes easy for the nursing team, because nursing head and the clinical nurse specialist being a part of that tumor board, they are able to understand the discussion there. They are able to understand the requirement of the consultant, the requirement of the patient. So our care pathways are already created. So standing instructions and care pathways are the only one thing which can bring in all these particular people together. Probably you're trying to talk about a pharmacy team, we are trying to talk about a clinical pharmacology, we're trying to talk about consultants, we're trying to talk about registrars, we're trying to talk about student doctors who are coming in to learn their DNB or DM programs. We are trying to talk about a novice nurse, a mid-level registered nurse, or a nursing officer, or a team leader, or a nursing specialist like this, a clinical nurse specialist. All these particular people should come in together. Along with this, there's also an important team who comes in place, is the purchase team, because they are the people who are trying to procure your drugs, keep it ready for the patient, and the pharmacy team maintaining those particular cold chain, or the handling, the storage, and all those things. So put a care pathways, build in a standing instruction, so that every team, it's not created to be created by a single person. It should be created as a team, sit for a discussion, create it, and there you go. You will have a flawless the work running in your organization.
Right. Thank you, Abdul, for clarifying this one. I'm sure Ms. Prisha would be happy to know the answers. Now, the next question is on the practice side. This is for the Groshang PIC lines. Do we have to flush each time with Heplock injection, or 30% normal saline is enough?
Okay, this is from where I didn't. I'm
Yeah,
sorry, really, I didn't follow your question. Okay, Venu is there, so Venu
Yes,
can
sir.
take
Yes,
it. Yeah.
sir. I'll take it. If it is like closed-ended catheter, normal saline flush is enough. If it is
Mhm.
open-ended catheter, double lumens and all, we need to flush, cat flush. That is contains like heparin 100 units. So that not each time. Whenever you are going to close the catheter, if you know it, like you are not going to use for 1 day or 2 days, or like few hours, if you're not going to use it, then you have to flush it with heparin. Otherwise, normal saline is, if you're using frequently, like continuously, heparin is not going to helpful. So you have to use only normal saline is, that is enough.
Right. Thank you.
That
Thank
too
you,
only
Venu.
in open-ended catheters. Closed-end catheters, heparin is not required.
Venu, I suggest you to be little more clearer on this open and the closed
Hmm.
catheters, so that people will
Yeah.
understand what is this open catheters and closed, and then say why heparin cannot be used and why normal saline is more important.
Yeah, if it is closed-ended catheter, like if you open the cap also, like backflow will not come because it has positive pressure. So until and unless we flush it, then only it will goes inside. Until and unless we withdraw, then only blood will come. So blood will not come automatically if you open cap also. That is closed-ended catheter. So in that those closed-ended catheter, normal saline flush is enough. If it is open-ended catheter, like just like center line, if you just forget to clamp it, automatically blood flows. So those catheters you need to flush with heparin at last, not in between like this thing. So if you're not going to use it for like 1 or 2 hours, if you're just clamping and leaving it off, then you have to use heparin lock. That too like only 100 units of heparin. That is diluted with the normal saline.
Right. Thanks, Vemu. There is one more question, which is what is the most common cause of CVAD blockage in onco patient, and how frequently do you find it in the patients?
Yeah. Like blockage, like usually automatically it doesn't get blocked. It is due to like if we have not air out the IV set, if it is sucking to the like IV set, if sucks it back, no. So again backflow will come till the subclavian vein or till the tip. So again it may get blocked. So always we have to observe for the whether fluid is going on or not. Whether if fluid has stopped for a long time, if IV set is connected and if fluid is not going. So if you don't do air out, so it may come, backflow may come and it may get blocked. And one more thing, like when we take blood sample, after taking blood sample, immediately we have to flush with normal saline. If somebody forgets to flush with normal saline immediately after taking blood sample, again that blood may get clot. No, only like for these two things we see like for the reason for the blockage.
Right. Thanks, Vemu. I think I hope the answer is received
And
by them.
clamping is also, yeah, clamping in open-ended catheter. If
Mhm.
we forget to clamp after flushing the catheter, so again backflow may come in the open-ended catheters. Always make
Okay.
sure when we flush, clamp.
Right. There is one more question from Mr. Gautam, which is when the line is on maintenance chemo, how frequently do we need to flush that line?
Yeah, every 7 days once, dressing and flushing is
It's mandatory.
mandatory. Every 7 days.
Right. Um, what is the most common reason for premature removal of PICC line or the peripheral catheter, we call it, and what are the what interventions can help overcome these?
Yeah, removal we don't remove like until and unless any problems we complications we see. Any
Mhm.
patient, if patient complains of pain, we screen for Doppler and all. If any block like DVT is there in subclavian or jugular vein or basilic or brachial veins, we'll screen for Doppler. If any DVT is there, then we have to give a coagulation profile like DVT prophylaxis, Clexane and all, and later only we have to remove it until and unless patient complaints of any this thing. So because 7 days once usually we'll keep on doing dressing, we also observe and monitor, and patients are, if patient is having any pain or any other problem complications, then only uh, we are going for removal. Otherwise,
Right, got it. So, there is a question which I've received in DM, which is about the patient education and the caregivers education. So, what are the most common and effective, what are the most effective ways to educate patients and caregivers on CVAD self-care and monitoring? This is
no,
important question. Yep.
no, self care is not allowed to, they, because patient always they have to come for dressing to the like concerned hospital only wherever they would put PICC line insertion, they should
Mm-hmm.
come to them only for dressing. They should not go to clinic and dress outside, any outside, because if they don't know how the dressing has to be done and how the flushing technique and all, So that is the important thing. They always, any problem, they have to confirm, they have to inform and confirm with the PICC specialist, with the hospital staff only. And whenever take bath, no, that time only they have to cover it with plastic wrapper or PICC shower cover. Only two things they have to take care. Only exercise is the one thing, and one more thing will be the whenever they take bath, we have cover it with the cling wrap. Those two things only we have told the patient. And one observation, any bleeding, oozing, this thing, they have to inform us. Only these three things they are following.
And
Because they should
adding
not
this,
take care of themselves. They should not open. They should not use at home. That's what we
Mm-hmm.
advise.
Right. Yeah, Asha, you were adding something?
and adding this, we are providing the education material to the patient. Once the insertion, the day of insertion, we are providing the education material to the patient, and attender education will be there
If
as
you
well.
could see this, I don't know
Mm-hmm.
whether my screen is visible now to
It's
all.
visible.
Yeah, so this is just a kind of a document what has been. It's just like a folding card what we try to give, and this particular card is given to all the patients who actually carry this home, so that they are able to come back with this particular card which has the basic details and then what is pick line and all those things. It's a multi linguistic card where we have, and the basic is this particular thing. So we are able to understand, if at all, say example, as Mr. Venu was trying to say, we don't allow patients to go to any other place to get dressed or get it flushed, so they are supposed to come back. But there are certain times when these patients are far patients where they cannot come, or they are stuck somewhere because they went to say most of the time this happens with this old patients, a kind of aged patient. They go to their daughter's home or son's place, they get stuck there somewhere out of Karnataka or something like that. That is the time when this particular nomenclature will help us, where we are able to have a kind of a tracking, which this card has to be carried by the patient whenever they're going for flushing, whether it is they come to our hospital as HCG or either they're going to some other place. We train and teach this patient attender to carry this card and ask the dresser or the doctor who's trying to flush the line to write the details here. What is the date? What was flushed? What was the dressing done? What was the black flow forward, and the flow and all those things, and write the details and comments also, so that we'll be able to know what happens. So earlier, this particular question was what happens to the premature, or what is the situation of having this premature pull. This is also one commonest reason. In India, handling oncology patients is very challenging when they go with these catheters back, because first and foremost, our patients are not too we have these divisions of patients, right? Well-to-do patients, financially moderate, and we also have majority of our patients. When we look into it, these patients come with an unprivileged background where they have a difficulty of handling this, and sometimes these patients are also the breadwinners of the home, so it is not easy for them also. So in such cases, it is also organization to decide on what type of CVAD has to be inserted. If such patients are, breadwinners, then it is more important a clinical team decides to go for a chemo port, because it's more safer than having a dangling PICC line or Hickman catheter otherwise, which is kind of covered within the shirt or something like that. So it's not greatly coming in contact and it's not dangling out, doesn't come out. So there are lots of areas, gray areas, where Indian populations or Indian oncology populations as patients undergo, and it is based on your environment, your society. Please look into your footfall of a patients, what is the background they're coming from, and then you decide on how it has to be done. Every oncology care has to be tailor made, not uniformly made across. Even HCG, we have 27 hospitals across, but our clinical care pathways are same. But such areas, what I'm trying to say, is all about tailored made based on the population, because we have centers in tier 1, tier 2, and tier 3 cities also. So based on that, the care and the not clinical care, I'm trying to talk about the rest of the care, gets changed here and there.
Right. Thank you so much, Abdul, for elaborating this one. There is a question which I've received in the DM, which is about the competencies that we look in an oncology nurse as far as the CVD care is concerned. So, particularly for oncology nursing, any specific set of competencies you may suggest? Maybe some aspiring nurses would be
I
asking this.
wouldn't tell. There are different competencies when you're trying trying to train or build an oncology nurse as such, right? So it is better to always give him or her a competency of handling CVAD also, because maybe a junior nurse, maybe a senior nurse, we may train nurses. It usually happens because even at HCG we always say to the junior nurse, we don't give this competency, we don't privilege them to handle central lines. It's because we have a clinical nurse specialist separately appointed for that. Every wing, every say about every consultant team, they have a clinical nurse specialist, so he or she is able to back up there in form of a nurse there, the bedside nurse who can do this procedure. If at all your organization is not having that liberty of creating a clinical nurse specialist specifically for department, specifically that designation itself is not there, what you do is try to train all the nurses, because at one point of a time this junior nurse will also be a part of a team who's handling the central line, who may not know how to handle it, right? Chemopods basically, or we're trying to talk about Hickmans, we are trying to talk about PIC lines. So it's very important. So when you're building a competency, please do build it, right? And there are lots of organizations which gives you a lots of a competency checklist. You can see oncology cancer societies. I have also come across, if I'm not wrong, Tata had published a few of the competencies list like that. That is can also be used because they are the forefront players of oncology in India, right? So that can be taken from there also, or the Oncology Nurses Society of International, like American, Canadian Oncology Nurses Society. They also give the competency, which you can download and then kind of tailor make according to your unit, which is required.
Right. Thank you. Thank you. Thank you, Abdul. I think Madhukari ma'am wants to add a few points from the INS perspective. Ma'am, you're there?
Yes, I'm there.
Right. Ma'am, just in the meantime, it's for all the attendees. There is a feedback link that Ipshita and Shinoj, they have posted in the chat box. Please do not leave the meeting without filling the feedback form. It would be very much important for us to align the next upcoming sessions of Ivy Talks. Yeah, ma'am, over to you.
Yeah, so I was listening to the discussions. It was really very, very strong discussions, and the questions were asked were very meaningful because these are the areas where our nurses are not able to decide at bedside what they should do and what they should not do. So that is one thing, and very nicely it has been explained also. What I feel is that after today, those who are posted, the nurses, those who are attending this session and posted in oncology unit, you can do a tracker sort of thing to understand that patients, though there are different types of patients, that patients are going with different lines. Also there are the long hours chemo with which we send the patient home. So with that the patients will have the pump with them, which is also a problem, like how they are supposed to be keeping their position of the area where where the PIC line is done. So the do's and don'ts can be given to them as a leaflet just to follow. And then any problem happens, what are the problems, what are the symptoms, which if they observe, they should bring it to our knowledge immediately. So that can be done as a QIP, as a quality improvement project. It can always be taken up for improvement. That's one thing that I thought of suggesting. And second is that I just wanted to say that Infusion Nurses Society India has thought of this need because every hospital now is coming up with oncology division, and that is the reason that oncology nurses need to be specialized in this. So we are coming up with different certification courses, which are with the help of industry partners, and our technical committee of INS India is developing this model. And then we will be really encouraging the nurses, those who are to take more membership, to be in touch with the INS India, to get this privilege to be certified in all these sections that you are coming across, because these are the questions that you are telling us. These questions you will get answer not only for the theory part, also for the practical part to comply with. So this will, I'm sure that this is going to give lot of ease at work for nurses that INS is looking for. Just I wanted to pass on this message because this is very apt for this topic. Thank you.
Right, right. Thank you. Thank you so much, ma'am. And we've come towards the end of our session, our November edition for Ivy Talks. And thank you to all these speakers, to Dr. Srinivas, to Venu, to Asha, and of course Abdul for taking it up. And it was really a very, very, very informative session. We've got a lot of questions. In fact, there are still questions coming up in DM, so we'll be sending that to you, and would request you to please answer those as well, because these are the queries some people might not be able to ask then and there. So we get questions, we'll be sharing with you. Thank you, Madhu ma'am, for joining in and accepting for the flag of the session. Last but not the least, thank you, Ipshita and Shinoj. You guys have been consistently, there for Ivy Talks, making it such a good platform. Thank you, all the audience, and thank you, sir. We will look forward to all of you in the next edition in December with some interesting topic. Do fill in the feedback forms. Thank you.
Thank you so
Thank
much.
you, Pooja, for hosting it. Yeah.
Yes, Polymed team, thanks so much for conducting this Ivy talks. It has been consistent. I guess every month we get this pop up of a reminder kind of Ivy talk is happening at one particular region. Thank you so much, and thank you for central leadership. Abinu ma'am, Madhukari ma'am, who are constantly, kind of behind improving the, intravenous nurses or any sort of a nurses who wants to get into IV cannulation in the practices. And every year we see an updated, handbook or the guidebook coming out with INS new updated standards. Thank you so much for the consistent job. And thanks to my team, HCG team. Though it was a last time reminder or a push, they made it well. Thank you so much. And thanks to the team. Thanks, Pinoj, for calling. He was also consistent to check if things are happening in the right way, because last time we had some issues with network. So thank you.
True.
Thanks for the participants for such an lovely questions, which you made also again think there are lots of take home. I'm also taking back, because I was thinking like, okay, few areas we are also trying to kind of miss. So definitely that will be put into place also. Thank you so much.
Thank you.
Thank you so much, sir, for the opportunity, and thank you whole team, the Polymet. Thank you for the opportunity. Once again, thank you.
Thank you.
Thank you, INS and Polymed team, and thanks to Abdul sir, Pooja ma'am, and Madhukari ma'am.
Thank you. See you all next time. Bye bye.
Thank you.
Take care all. Bye bye.
Thank you, everyone.